Welcome to the ASCO University Weekly Podcast. My name is Dr. Daniel George, and I'm a professor of medicine and surgery at Duke University. I'm also the director of GU Oncology at the Duke Cancer Institute and co-chair of the DCI Center for Prostate and Urologic Cancers. Today, we'll discuss two similar cases of patients presenting with metastatic renal cell carcinoma and our multidisciplinary management options. Without any standard screening procedures, 20 to 30% of kidney cancer patients today present with metastatic disease. Historically, debulking nephrectomy has been our standard of care, and this has been based on old trials from the interferon era of treatments. Since then, many drugs have been approved for the management of patients with metastatic renal cell carcinoma, many of which have improved the progression-free survival and overall survival of patients with metastatic disease, which may have had an impact on the landscape and role for debulking nephrectomy. Furthermore, metastatic kidney cancer patients can be risk stratified. There's a number of criteria used, but historically, the most commonly used criteria has been the Memorial Sloan Kettering Cancer Center criteria, which included 5 factors, including KPS score less than 70, a calcium score greater than 10, a serum hemoglobin of less than the lower limit of normal, an LDH greater than 1.5 times the upper limit of normal, or having their primary tumor in place, meaning no prior nephrectomy. If patients had 0 of these factors, they're considered good risk with the best survival. Patients with 1 or 2 of these factors are considered intermediate risk. And patients with 3 or more of these factors historically have been very poor risk, with median survivals of 6 months or less. The Carmina study was a prospective, multi-center, randomized non-inferiority trial comparing upfront nephrectomy followed by sunitinib therapy compared to upfront sunitinib therapy alone in patients with metastatic renal cell carcinoma amenable to cytoreductive nephrectomy. We'll get to these results in a moment, but the study population included, importantly, patients with ECOG performance status 0 or 1, and 40+% of these patients were considered poor risk, with the average sum of metastatic tumor burden being greater than 5 centimeters. So now let's get to some modern cases. First case we'll discuss is George. He's an 83-year-old man who presented with gross hematuria and a hemoglobin of 13.8 in the normal range. A CT scan revealed an 8-centimeter right renal mass and multiple pulmonary mets up to 2 centimeters in size. His ECOG performance status is 0, and his calcium was 8.4 and LDH was normal as well. Our second case for comparison is Philip, a 76-year-old man who was found to have a 16-centimeter left renal mass incidentally on a spine MRI. This was confirmed by CT scan, along with some pulmonary nodules measuring up to 1.8 centimeters, as well as enlarged mediastinal lymph nodes up to 2 centimeters, and an 8-millimeter liver lesion. His calcium score was 10.4, and his hemoglobin was 12.5, which is below the limit of normal. He had a normal LDH and an absolutely 0 performance status. So for these two cases, we have 4 choices. The first choice is for both cases, a nephrectomy followed by systemic treatment, our historical approach. The second is systemic therapy first, with plus or minus a subsequent nephrectomy for both cases. Our third choice would be to treat case number 1 with a nephrectomy followed by systemic therapy, and case number 2 with systemic therapy first. And our fourth option would be systemic therapy first for case 1 and a nephrectomy first for case 2. Now, to me, when I look at these cases, the correct answer is 3. Nephrectomy first for case 1 and systemic therapy first for case 2. Let me explain. Even though these cases are fairly similar in age and gender and performance status and the presence of a large primary tumor, for case 1, this is an intermediate risk patient. This patient has lung-only disease that's relatively low volume, a good performance status, and normal labs. In addition, he's symptomatic with gross hematuria. For these reasons, a debulking nephrectomy is really indicated, and because of his good performance status, he's very likely to recover well from the surgery despite the fact he's 83 years old. Case 2 is subtly different. This is actually a poor risk patient. Even though his ECOG performance status is 0, he has an elevated calcium, a decreased hemoglobin, and he's got his primary tumor still in place. That puts him into a poor risk category. And some of these patients never recover from surgery well enough to get systemic therapy. He also has multi-organ involvement, involving his lungs and nodes, and possibly even his liver. This is a patient that really mirrors the patient population of Carmina. Based upon this, I think systemic therapy first is a reasonable treatment option for this patient. If we actually look at the results of Carmina, the study confirmed that sunitinib therapy alone, systemic therapy, was non-inferior and actually trended towards improved survival compared to cytoreductive nephrectomy followed by sunitinib. The results suggest that for poor risk or for high volume metastatic patients, that systemic therapy first should be the standard of care. But importantly, not included in the Carmina study were patients that had low volume metastatic disease and intermediate risk features and are good prognosis. These patients, not included in the Carmina study, might still benefit first from a debulking or cytoreductive nephrectomy. So thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on the role of cytoreductive nephrectomy, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.